Yeah, good morning from Vienna. I hope you can see the screen. My name is Helmut Prosch. I'm a thoracic radiologist here at the Medical University in Vienna. And I'd like to thank the organizers for having me here at this important meeting. Here are my conflict of interests. None of them are pertinent to this presentation. So in my talk, I will tackle a couple of things in regard to lung cancer screening. First of all, I have to answer the question, why does lung cancer screening make sense? Then we will focus a little bit on the results of the screening studies, and then I will give you some insights on current and ongoing and planned European screening projects. In the first presentation, you already learned, and I'm sure you already know, that lung cancer is a healthcare problem in Europe and throughout the world. And as 20% of all cancer deaths in Europe are related to lung cancer. And in fact, every 2 minutes, a European citizen dies of lung cancer. So there is a substantial impact of this disease. And one of the reasons why lung cancer is such a devastating disease is the fact that most lung cancers are detected in an advanced tumor stage, meaning there are already distant metastases seen at the time point of diagnosis, and only a limited number of patients present in a tumor stage in which a resection of the tumor is still possible. And this directly translates into mortality. As you see in patients with a distant spread of the disease, you see a 5-year survival of as low as 6%, whereas in patients with a localized disease, meaning a resected disease, there's hope for cure, and the 5-year survival is almost 60%. And this translates to this devastating 5-year survival of 20% in lung cancer. So the idea to diagnose cancer in an early stage is not new. Already in the last century, meaning in the 50s and 60s of the last century, a number of investigators looked for a possibility to detect lung cancers in early stages using either chest radiographs alone or in combination with sputum cytology. However, if you look at this chest radiograph here, it's quite apparent that this is not that easy, as the detection here of these nodules, as is encircled here as well, is not that easy. They are not that easy to see. And the lower limit, what you can see on a chest radiograph, is a tumors of about 1 centimeter. So although these screening trials could show that you can detect early stages of lung cancer, this did not translate into an improvement of mortality. New hope came up with the introduction of these CT scanners we are used to use now in our daily routine. And in particular, the introduction of the thin section CT, which made it possible to see also these tiny nodules here, as you can see here, with a low radiation dose, increased the hope that lung cancer screening using CT may be able to save lives. And the first evidence that this is a feasible method came from the National Lung Screening Trial, the first randomized prospective controlled trial. And this was run between 2002 and 2004, and then patients were followed over the years. This was a huge study, a multicentric study involving more than 50,000 participants. And what they did in this study is they included active smokers with more than 30 back years, meaning these persons smoked more than one packet of cigarettes over more than 30 years, or for the former heavy smokers who stopped smoking within the last 15 years. These persons had to be between 55 and 74 years of age. And they were then randomized into 2 groups. One group was screened in 3 times using low-dose CT. The control group was screened using chest radiographs. So this stands for chest radiographs. And this was no big surprise that in chest radiographs you see more and more death from lung cancer over the years. So these are years versus the detected lung cancer death, and this is expected. Yeah. And then the big surprise was that we could see the positive effect of low-dose CT screening on lung cancer mortality already after 6 years of observation. And in fact, this study had to be stopped after 6 years prematurely because this positive effect could be seen already after 6 years of observation. But you must not forget that patients still die from lung cancer if they are getting screened. So it just reduces the number of patients dying from lung cancer. It does not stop patients from dying from lung cancer. This is an important message which has to be translated also. We have to tell also our patients and persons interested in screening. Overall, there was a reduction in mortality of about 6.7%. Patients die also from other causes. Remember, these are heavy smokers. The number needed to screen, meaning how many persons do you need to screen in order to save lives, was 320, which is excellent already. Importantly, the majority of persons included in this trial were male, and I will come to that point later. That's really important. However, they already saw a slightly higher benefit for females. And this is important, and as I mentioned, I will come back to that. The result of this national lung screening trial were so good that a number of American societies recommended then lung cancer screening, and also the European Society of Radiology and the European Respiratory Society and a couple of other European societies were positive in favor of lung cancer screening. However, there was still some reluctance in Europe for the implementation of lung cancer screening. This is for a number of reasons. First of all, there were questions in regard to the generalizability of these NLSD results, National Lung Screening Trial results, because these were performed in centers of excellence, and the demographics might not be the same as in Europe, as well as the inclusion criteria, which probably included more healthy volunteers than patients at risk for lung cancer. And then there are also potential harms and complications in lung cancer screening. First of all, if you detect nodules, they need to be investigated, and the invasive procedures, meaning biopsies or resections, are associated with risks. Then there was, back then, primarily the fear of radiation dose, and then the fear of overdiagnosis. So we waited for the results of European trials. There were a number of trials up and running until now, and most of them have published their data already. There were 3 Italian studies, mainly run in the northern parts of Italy. Then this big Nelson trial, the biggest of these studies, involving more than 13,000 participants. Then studies in Denmark, in Germany, as well as in the UK. And as you can see here, the number of included participants was rather low. Only the Nelson study had a higher number of patients involved. I mentioned already 13,000, more than 13,000. So just to illustrate what we're doing here and what are the problems, what we are doing in lung cancer screening, we're looking for early signs of lung cancer. And this is what we call a pulmonary nodule. And these pulmonary nodules are something we see quite frequently also in healthy patients, and most of these nodules are benign. In fact, if you look at all the pulmonary nodules detected on a CT screening, most of these nodules are very tiny, and of these tiny nodules, they are almost always benign. And the larger these nodules are, the higher the probability that they are malignant. So size is really important predictor for malignancy. And this is important to take into account. And we must not overmanage nodules. So not every nodule detected in lung cancer screening needs to be investigated invasively. In fact, most of the nodules need to be followed just over time, and we need to avoid a biopsy. Because major complications occur, and in the National Lung Screening Trial, major complications occur in 3.3% of the participants of the low-dose CT group. That's quite significant for a diagnostic procedure, I have to remind you here. And then also death occurred. It's not that common, but still, that's cumbersome for a screening. So we have to be more diligent. We have to find ways to investigate these knowledge without harming the participants in a screening project. So the general concept here is, without going into details, very small nodules do not require any further management, and they just go to the next screening round. If nodules are large, the risk of malignancy is quite high and they need to be further evaluated, be it a biopsy, a resection, or a PET-CT. And then there are nodules in between, which I call here just small. And here we usually perform a follow-up CT scan depending on the risk, individual risk. And then if the nodule remains stable, meaning it does not grow fast, the patient goes into the next screening round. And if there is a growth, again, there's a further workup. The intervals between for the follow-ups as well as the definition of very small, small, and large vary from study protocol to study protocol, but this is just the gist of it, what we are doing here in the management of nodules. And in an NLSD, this was not that well defined. Remember that was back in the days in 2002, a long time ago already, and back then they defined any lesion larger than 4 millimeter or larger as a positive finding. And by using these criteria, more than almost 40% of patients, of these persons screened or in these 3 screening rounds had at least one positive scan. And among these positive scans, only 3.6% were malignant. So most of these nodules are benign. And this is really important to keep in mind and also to address when it comes to the discussion with investigated persons. So measurement of nodules is important, but the measurements are not that easy. So if we are measuring nodules like that, and I ask some of my residents to measure these nodules, you see here there's quite a variability in the measured diameter of these nodules. But this has an impact as we know that every millimeter counts here in the risk prediction. Problem is that using our conventional calipers, any change less than 2 millimeters has to be discounted, as this is within the limits of the method itself. So what we can do, and this is what was done in Europe in contrast to the US, we were using primarily volumetric software in order to measure the nodules. As you can see here, nodules are frequently not completely round, but they have also a complex structure. And with a volumetric assessment, you can able to better assess the risk of nodules. And this was done, as mentioned already, in the European studies, and in particular in the Nelson study. Remember the study from the Netherlands. And they involved active smokers, but the smoking history had not to be that much as in the American study, and also former smokers with an age between 50 and 74 years. Again, there was a randomization, but in contrast to the LSD, the control group was just the usual care, so no intervention. And the persons investigated in the screening got one baseline screening, then one after 1 year, another one after 2 additional years, and then a last one after 2.5 additional years. And the good signal here was that we see here a clear improvement in lung cancer mortality overall in male persons of about 24%. And if you just look at women, the effect is even bigger. However, the problem is that the Nelson study was started under the assumption that male would profit more from lung cancer screening than women. That's why it was saturated with male persons. So the researchers could not reach a statistical significance. However, the signal is clear: women profit more from screening than men. And this was also seen in the German Lucy trial. The males did not profit that much from lung cancer screening, whereas women profited a lot more from lung cancer screening than male persons. Going back to the results from the Nelson study, I mentioned already there were so many positives in the American study, but it's the helpful signals we get from Nelson trial. If you are performing and using a very sophisticated nodule management protocol, you can reduce the number of patients requiring further investigation and just then limit the potential complications a lot. What they did is they just had to send 9.2% of the persons to follow-up scans and a much lower percentage of persons to further workup. And overall, just 2.1% of these persons had a positive scan, which is really low, and the more surprising result was that most of these were malignant. So this is really an effective way to identify malignant nodules. And this is, I think, the biggest achievement of the Nelson trial, that it could show that using such a sophisticated management protocol, you are able to keep the number of false positives very low. Okay, so by following patients, and this is so important also that you reduce the number of persons which are followed over time. You have to reduce that in order to achieve two things: in order to keep radiation dose low, and then also to keep costs low. When it comes to radiation dose, this was a reason for concern in the old days, when the radiation dose of CT scans was quite high. But nowadays, we are using low-dose CT scans in our daily routine, and using the radiation dose in screening can be very, very low, can be in the range of a overseas flight from Europe to Japan. So, 3 times the dose of a flight from Europe to Japan. So we are able nowadays to keep the radiation dose very, very low. When it comes to costs, the cost estimates need to be calculated for each and every country. But if you look at the quality-adjusted life years saved for lung cancer screening, this is significantly lower than the costs for one of these modern treatments, like osimertinib, the EGFR inhibitor, which is nowadays routinely used in the treatment of advanced stages. And if you are reducing the number of advanced stages, we can also reduce the number of patients needing this long-term treatment with these expensive drugs. What we can also do in lung cancer screening, in contrast to other screening protocols, we are able to tailoring our screening population down to the persons who would profit most from lung cancer screening. In breast cancer screening, we just set two limits: gender, so it's female persons which are screened, and then age, be it 40, be it 45, as the limits or as the inclusion criteria for screening. In lung cancer screening, we can tailor our screening population to the persons with a high risk, or even further narrow it down to a smaller group of persons we need to screen in order to achieve an effect. There's one other thing to mention, which is smoking cessation. Smoking cessation is the most important intervention to decrease lung cancer mortality. That's nothing new. And the effect of smoking, this intervention is in the range of what we see in lung cancer screening. So it makes totally sense to combine smoking cessation with lung cancer screening, as this then adds up, and this is an estimation from the NNST, that if you combine lung cancer screening with a smoking cessation program, you are able to further improve the effect of lung cancer screening. The reason why we need to perform screening and not just start with smoking cessation programs is that the effect of the cessation programs is something we see in a midterm interval. We don't see this effect right now. We have to wait for years to come to see this effect on reduction of lung cancer mortality, because the lung cancer screening effect is something we see already now, and if you combine both, the effect is much higher. So if you look now at the potential harms versus benefits in lung cancer screening, you will realize that the benefits outweigh the potential harms of lung cancer screening. However, you have to be careful, and you have to make sure that you are running lung cancer screening in a controlled program in order not to come up with a high number of false positive results, overdiagnosis, treatment, you name it. So lung cancer screening is something which needs to be done in a systematic way. It should not be done should not be left to private practices without any clear program. And the effect of lung cancer screening is there, and this is the reason why the European Society of Radiology, together with the European Respiratory Society, already published in 2015 a white paper which suggested the implementation of lung cancer screening, which was then followed. This paper was then followed by an expert paper published in Lancet Oncology on lung cancer screening, again recommending lung cancer screening for Europe. And only last year, again, the European Society of Radiology and Respiratory Society published a statement paper on lung cancer screening, and here again suggesting the implementation of lung cancer screening. What did we see so far in Europe? Not that much, unfortunately. Given the huge number of countries in Europe, there's only one country in Europe, Croatia, which started a nationwide screening program last year. And the colleagues there have to be congratulated for their efforts. This is the first European and first worldwide nationwide screening program. Not even in the US we have a nationwide screening program. And this aims to screen 50,000 heavy smokers between 50 and 70 years of age. The recruitment is done by general physicians in 16 sites all over the country, 12 cities, 16 sites, and it is covered by national health insurance funds. This program started already in October last year. The start was somewhat delayed due to COVID. This case has to be expected. And the screening occurs after regular working hours, so there's the number of diagnostic CT scans, meaning patient scans to investigate patients with cancer, with known cancer, and so forth, is not reduced. This is done after the regular working hour, and is also paid extra to the radiologists performing these scans. They had to start this with extra special COVID-19 precautions, and so far, this is data from a month ago, they screened more than 900 participants. Another screening program coming up in the next month is a screening program in Hungary. In Hungary, they had already a prospective study which ran between 2014 and 2019. It was done in 4 centers. It was an opportunistic screening, and they performed this to calculate the cost effectiveness of lung cancer screening in Hungary. And until then, they screened more than 2,000 persons and detected lung cancer in 1.1% of the screened persons. Now they are starting with a broader screening program, which was planned to start in October 19, but then was delayed due to the COVID pandemic. They're using a central computer-aided diagnosis software, which solve also diagnostic problems we have, and did not get into that. And they use, and this is important, an online registry of patient data in order to be able to benchmark with the screening data of other countries. And they are now modeling a patient pathway from positive scan to definitive diagnosis. And in the second half of last year, they had 10 more new centers. Besides these two countries, just to mention these 2 countries, we have also the screening project in the United Kingdom in more than 14 sites all over the UK. We have a implementation study in Poland, also implementation studies in France, as well as in Austria. What is also important to provide a screening with a high level of quality, and for this reason, the European Society of Thoracic Imaging implemented a lung cancer screening certification project, which helps countries to implement lung cancer screening in Europe, because it is important to get to gain from the experience from other countries and to gain from the experience from specialists. That's why we implemented this certification project, which will allow this speeding up of the implementation of lung cancer screening. In summary, lung cancer screening is effective in high-risk populations. We learned this from a number of screening studies. Women appear to profit more from lung cancer screening. The adverse effects and potential harms are overcompensated through screening-induced mortality reduction, and screening should be combined with smoking cessation interventions. And the final message is implement lung cancer screening now. Thank you very much.